We've known for a long time that the covalent BTK inhibitors, over time, patients will develop a resistance mutation in the target residue to which those drugs bind covalently, namely the cysteine 481. And the most common mutation changes that from a cysteine to a serine, abrogating covalent binding. Now, ibrutinib still has some activity as a non-covalent inhibitor against the mutation, but acalabrutinib and zanubrutinib don't. But we see that mutation quite commonly with any of the three covalent inhibitors. Now, recently, a wealth of data has come out related to one of the non-covalent inhibitors, pirtobrutinib. And pirtobrutinib was designed to have activity against the C481S mutation, regardless of it. As a non-covalent inhibitor, it's not that dependent on a single residue and touches down in other spots on BTK. And so, in fact, it does have significant activity against C481S. But what was seen by several groups, and including data that I presented at EHA from the Bruin trial on 49 patients, is that the C481S mutations go down on pirtobrutinib, but then other mutations come up, other sites. T474I, which is called the gatekeeper mutation, L528W, which is a kinase dead mutation. And that brings up just a couple interesting points about the mutations that we've been seeing on pirtobrutinib. So we know that C481S still activates the B-cell receptor signaling pathway. And that's true also of the T474 mutations. But the L528W doesn't activate the pathway proximally. You don't see BTK autophosphorylation. And this is also true of a number of the other C481 mutations, R and F and Y. They're so-called kinase dead and don't activate phospho-BTK. So the question comes up, how did they work? And that's still an open question, but it's been raised the possibility that the BTK scaffolding function may be important, where other kinases are assembled on BTK, but we don't require the kinase activity of BTK. And so that's something that is a matter of ongoing investigation, which we and others are working on. Another interesting point that has emerged recently from the ELEVATE-RR data, as well as some data on zanubrutinib, is that in addition to C481 mutations, it seems that we're seeing more of these other two mutations associated with pirtobrutinib resistance in patients on these covalent inhibitors. So T474 comes up with acalabrutinib. We saw in the ELEVATE-RR data more than ibrutinib, although you can see it occasionally. And L528W in very limited data also seems to come up with zanubrutinib. Now, they're both less common than C481 with acala and zanubrutinib, but this has raised questions about sequencing and what the impact of having the mutations may be. In the pirtobrutinib data, we did see that patients with very low levels of these mutations, very low varying allele frequencies down in the 1 to couple % range, would still respond to pirtobrutinib and could still stay on pirtobrutinib for some time.